Just a little bit about us. We are the IPRO QIN-QIO. We're a federally funded Medicare Quality Innovation Network quality improvement organization contracted with CMS, and we are one of 12 regional organizations nationally. We have 3 organizations under the umbrella of the QIN-QIO: IPRO, Health-Centric Advisors, and Clarent, and we work to ensure high-quality, safe healthcare for Medicare beneficiaries. So I'm extremely excited to introduce Dr. Elizabeth Talbot for our second session in our Bivalent Booster Hesitancy series, Setting the Stage for Success. Dr. Talbot is a professor in infectious diseases, physician at the Dartmouth Geisel School of Medicine in New Hampshire. She's also the New Hampshire Deputy State Epidemiologist. And with that, welcome, Dr. Talbot, and I will turn the slide sharing over to you.
Fantastic. Confirm that you can see my slides then.
Yes, they're all set.
All right. Excellent. I'd like to commend you on joining. I myself have an awful lot of COVID fatigue, pandemic fatigue. I'm tired of talking about the vaccines. I'm buried under preprints, late prints of papers coming out. But what I'd like to do today is offer you some quick updates and then the all-important talking points that are going to help you in the trenches where you are. So conveying some of, I think, the anxiety of the amount of information we're getting about these and sometimes how very technically complicated. We're going to talk about safety, efficacy, and Omicron boosters. Oh my. So please do chat questions because that will make it more valuable, likely for everyone. And not holding any cards close to chest, I'm actually starting with a summary in case you get called out to other duties or so. Yes, we're in the transition phase of the pandemic. We are no longer in the emergency phase, but it is by no means over. I don't know what the future holds in this regard, but I do suspect that we're all going to need to stay attentive to the evolution of mitigation tools. Speaking of which, the mRNA vaccines are without doubt safe, effective, and the most likely tool to reduce morbidity and mortality in our facilities, in our states, in our country, and globally. So we've got to talk about Omicron. It's uniquely capable of evading immunity, and it is our future. Some of its features make it seem almost like a new pandemic. The bivalent Omicron, two words bivalent, so twice bivalent, boosters show greater neutralizing antibody protection and prevent this morbidity and mortality. So in summary here, the bivalent booster is where we need to be right now. And yet vaccine hesitancy continues to be our collective challenge. If you have not been paying attention, the current COVID-19 vaccine recommendations are quite simple. They fit on this one single slide, even with the picture taken up half. Everyone 6 months and older should complete a primary series. Whether your primary series is 2 or 3 doses depends on your age and whether you have an immunocompromising status. Pfizer or Moderna vaccines are for persons 6 months of age and older, and we have the backup vaccine of Novavax. It's available for people 12 years of age and older. So when you have a person who is unable to take mRNA, a very rare scenario, but it does occur, then Novavax is the backup. Everyone 5 years and older who has completed at least the primary series, and I mean by at least to say no matter how many boosters you've had, just stop counting those. Anyone who has completed their primary series, no matter how many boosters they've had, should now receive one bivalent Omicron booster. It's available for those 12 years and older since September 1st, and then the age bracket of availability dropped down to 5 years since October 12th. So we're in a great place with simple guidelines and availability down to young age. And yet this is what we're observing. This is pulled from the New Hampshire jurisdiction. I think that without dwelling too much on the sawtooth, the numbers, we are noting, of course, that there's an increase in the number of persons who are hospitalized and being treated for COVID-19. And then tragically, we are observing a sustained daily death incidence of about 3 people a day in New Hampshire, with that number increasing as well. So uptake of the vaccine in my jurisdiction is as follows. This is pulled straight from our website, available to all, showing that the older you are, the more you recognize that you're in the crosshairs of this virus, and the chances of bad outcome are higher, and therefore people are accessing primary series. More than 99% of those 65 years and older, which is just remarkable. However, really there's no bragging rights around the proportion of the population in any age bracket who's received the bivalent booster. So that's where we are. We're looking for setting you up for success in these discussions. It's important to know what's likely to come back to you when you engage with your patients and your colleagues around this. In New Hampshire, we have this great resource of the UNH Survey Center, which is a representative sample of our own state. And you won't be surprised, I think, to see these data shown in most recent iteration for reasons adults don't get the vaccine. This is just generically the COVID-19 vaccine as of October 2022. So out in the largest ugly brown bar is they don't trust the vaccine to be safe. This has been true all along. We're going to have to talk about that. When it comes to people who have decisions made for them, such as for children, parents have a slightly different reason for not vaccinating their children. This is very a little bit dusty data, but there is a perception among parents that kids are just going to get these infections and the vaccine isn't really going to help. They also believe that COVID-19 in general is milder for children. That's true, but of course, in a quick response, they still are subject to long COVID, increased incidence of type 1 diabetes and other bad outcome, of course. There's lack of trust of the pharmaceutical companies. And then here again, at nearly 50% is a report that they're concerned about safety. So let's do it. This is critical knowledge to support uptake and ensure that we can have informed conversations with our constituents. So the safety monitoring systems, there are several. These are the 2 that are most regularly reported on. One is VAERS. We all know VAERS. You're required to report all serious adverse events, whether you think they're related to vaccine or not, just if they're in proximity of receipt of a vaccine. And it's an early warning system that detects potential safety signals for all vaccines. It does not establish causality, of course, because everyone can report everything into it, and it requires an analysis once there's a signal seen. And then there's the more unique era of VSafe. This is a voluntary smartphone-based system. I bet many of you are participating in that or have participated in it. My husband used to say, well, at least VSafe cares about me, because they were always asking how he was doing post-vaccine. We do expect, and I think this will make sense to you, that there may be an overrepresentation from those who have side effects, right? If you're feeling quite fine going about your daily business, you might not want to take a moment and do the few question survey. But with that said, it's given us a tremendous amount of very reassuring data. In this review, in our high-tier journal, Lancet Infectious Disease, they looked at the safety of these vaccines in the first 6 months of the vaccine program. And there are several bubbles here that are meant to give some talking points. First of all, the extraordinary number of doses that have been given in the US and globally, with some predominance of Pfizer-BioNTech. There's an analysis of safety in those 16 years and older in both of the systems just alluded. And please do focus here. This is reproducible from lots of different studies. Serious side effects are rare with the mRNA vaccines. And yet we expect local injection site and systemic side effects. These are common. These are common for this vaccine and for others. You know, we hear that for our patients who are receiving the varicella-zoster vaccine, for example, or Tdap with soreness in the arm, and et cetera. So there's nothing unusual about what's happening here. These are usually mild and moderate in severity. They usually occur shortly after vaccination. No kidding. We're training our immune system to gear up, and that feels uncomfortable a little bit, but they resolve remarkably quickly. There's so many studies and even anecdotes saying that I felt like crap, and then 5 minutes later I was fine. You know, that the off button is really kind of strangely sharp for the side effects that people have. They resolve very quickly. They're more common following dose 2. Well, that's intuitive. People have primed their immune system, so there's a more of an ability to react when you get that second dose. And then side effects are slightly more common with Moderna versus Pfizer-BioNTech. This is related to the encapsulation that the companies have created for these. Slightly more immune stimulating with Moderna also plays out with durability and a little bit better vaccine effectiveness, but not so much so that we should sway our patients one way or another. Within the VAERS reports summary, where people can report anything that happened to their patient in proximity to a vaccine, there are more than 340,000 reports. 92% were completely non-serious, just in the category as described. 7% were serious, and 1% were deaths. So, you know, thoughtful pause, that is a number that sometimes comes back to us, and we need to understand it better, because this is publicly available information. So, you know, when you say 1% of deaths in the first 6 months of the vaccine rollout, that can sound pretty significant with a huge denominator like this. They have done multiple analyses of the deaths that are reported through VAERS, and repeatedly there, in quotes, there are no unusual patterns in the cause of death among the death reports. In fact, because rollout started in long-term care facilities, assisted livings, and among those with significant medical comorbidities, it's not a surprise that some of those folks were likely to die in the time period. Some significant proportion of deaths were also even among those who got vaccine while they were on hospice. So most deaths were due to heart disease, and 13% were due to COVID-19. Either in an interval that was too short for them to have achieved protection from their one vaccine, or between their first and second. So you see that this is hardly of concern. So note those talking points, I think, that can be helpful when we talk to our constituents. Of course, we need to have the analogous language for safety among children and adolescents. All data consistently show that mRNA vaccines are similarly safe. In fact, there may be even a lower rate of some of the expected side effects in the youngest children, in part because the dose is lower and their immune system is less mature. So, you know, all good headlines. I've given you a bunch of references if you have time and inclination to look those up. Okay, we got to take on myocarditis pericarditis. This was a super bad day when this started coming and grabbing all the headlines. So first, if you're not fully aware of what this inflammation of the heart muscle or inflammation of the sac around the heart means, it's well known for clinicians that there are multiple causes. Sometimes it's completely idiopathic, we don't know, but often we identify an infection. An inflammatory response, that is after a vaccine, for example, or toxins, or even autoimmunity can cause. And what I'd like to give you as a talking point is that COVID-19 itself is a powerful cause of myocarditis. And if possible, may I invite you to mute. Thank you. I'm easily distracted in my state of COVID fatigue, so thank you for muting. But yes, we show all of our cards with regards to the all-important conversations around safety, and mRNA COVID-19 vaccines have been associated with the development of myocarditis and pericarditis. This is highest in adolescents and young adult males. It's usually after the second dose, suggesting that their immunity has a role, and it often occurs in the first 7 days after that vaccination. So nearly all persons who develop myocarditis, pericarditis after vaccination do recover. The reason it doesn't say all is that some cases continue to be followed for full credibility. but I'm not aware of any deaths due to myocarditis, pericarditis after vaccination. And in fact, the CDC has provided us with some very nice data and graphics to accompany the MMWRs, two of which I'll show you here. First, myocarditis occurs more frequently among COVID-19 patients. So making that point, that infection itself is a potent cause of myocarditis, pericarditis, in fact, 16 times higher. If you have COVID-19, are you likely to have this syndrome? Vaccination is the best way to protect against COVID-19 virus-related complications of all kinds, including myocarditis, pericarditis. And then to bring it home a little bit more closely, the risk of heart complications is higher after COVID-19 infection than after mRNA vaccination among the target population of males, but also of females of all ages. So the take home is that teen boys who are at higher risk for myocarditis, pericarditis with vaccination have a 2 to 6 times higher rate after infection compared to after vaccination. And that is even more pronounced in the early adult age. So these are nice graphics if you want to grab them for your waiting rooms. Yes, these systems are in ongoing surveillance mode. And in this boring slide, I want to show you leading the news, even raised to me on a daily basis since announced January 13th. The FDA CDC announced that they had detected a preliminary statistical signal in a different data set, the Vaccine Safety Data Link system, that has prompted them to conduct a systematic investigation about whether people 65 years and older are more likely to have an ischemic stroke in the 3 weeks following a Pfizer bivalent booster compared to a later time period after vaccination. Okay, so you see what's happened. They're monitoring these systems all the time, and they got a little signal that meant they needed to be responsible to investigate. And I do think they were credible to announce as well, although it's tough on us to constantly understand these things and defend these things. The most recent reports yesterday are an aggregate of expert opinion that this is likely not a true signal. And some of the evidence for that is that there is no such signal seen in 3 other federal vaccine safety tracking databases, including VAERS and VSafe. It has not been seen in Pfizer's global safety database, which is huge, with more than 20 billion doses given, like a massive denominator. It's not been seen in other countries' monitoring systems. We're not the only ones who have systems like VAERS and VSafe. And it's not been seen with Moderna bivalent, which is so closely related. So that aggregate of data makes us think this signal is very small, if real at all. And all these data are going to be reviewed by the FDA at a January 26th public meeting. So if you want to follow that, I encourage you to do so. In summary, it's all good with regards to safety. Local and systemic side effects are common. Great, your immune system's doing what it's supposed to. Patients should be counseled to expect that. It's in the 1 to 2 days after vaccination, and symptoms usually quickly subside. Serious side effects are rare. You need to have something up your sleeve with regards to myocarditis and pericarditis. I've given you some of that. COVID itself causes more myocarditis, pericarditis than a vaccine has. And nobody has died from this syndrome after their second dose of vaccine. There are multiple safety surveillance systems that are ongoing, such as detected this possible signal for ischemic stroke. So let's talk about Omicron variants in a little bit more detail and give you some talking points there. Who cares? You know, we've been Delta, we've been ancestor strain, we've been Beta, Gamma, whatever. What's different about Omicron? I think you have inevitably heard it is better at evading immunity, both from the original vaccines and also from having had disease itself. The alphabet soup of the great-grandchildren of Omicron is getting pretty darn confusing. I like this graphic from Nature, which is, again, a really super high tier journal that's put together this nice summary for us, where you can see Omicron emerged from a daughter strain of the original Wuhan strain. It's split to BA1, 2, which has been predominant in Europe, and then further evolved to BA4, 5. And now the variant soup includes these 2 bad guys I'll show you in more detail, BQ1 and XBB. So CDC is tracking the emergence of the Omicron variants, and without a doubt, we are now in the Omicron grandbaby era, where we have XB.1, 0.5 in this pretty purple color, 43% of national strains. It's higher in New England. So we know that there's a predominance in New England. BQ1 and BQ1.1 account for a similar approximate amount. So half is XBB 1.5, half is BQ1 and 1.1. So it's worth knowing that nomenclature, because this is what we're living with right now. So the boosters are coming amidst a tremendous pandemic fatigue. I'd like to frame it as, thank goodness we have boosters that are now addressing what's almost this new pandemic of Omicron, but it's falling on a lot of deaf ears, isn't it? We know the variants substantially impact vaccine effectiveness and durability of immunity. So this slide summarizes this with important note on this third bullet, if you will, that even though we can have disease breakthrough, the vaccine effectiveness against those serious outcomes like hospitalization and death is still present and retained, but Omicron variants want to subvert our ability to control transmission of this virus. And the updated bivalent Omicron booster definitely increases protection. I'm getting the question all the time from my own patients, my family, my circles, do I need that bivalent vaccine or the Omicron booster or whatever people want to call it? There are 8 excellent lab-based studies, all consistent, showing about the same incremental protection compared to the original boosters. So that's considered quite credible. And more compelling for many is the real world data that's emerging. It's all coming in consistently that the bivalent booster protects against hospitalization and death. I offer you this slide with links to 3 important studies. And if you just follow with me in our dwindling moments, that the number 73%, 90%, and 81% are reduction in serious outcomes for those who got bivalent booster, either compared to regular booster or being unvaccinated. So the devil's in the details for you to convey this information credibly, but in general, the summary is real world data is showing that people are less likely to be hospitalized and die if they elect the bivalent booster compared to the monovalent. This is especially true in the elderly. So of course, wait, I'm younger, do I really need that? So I think that this is helpful, this data that just came out. It's a study of adults 18 years and older, but including younger ages than the previously mentioned studies of those 65 and older, that found the bivalent booster was 38 to 57% effective against hospitalization, which is at a lower magnitude than that seen for the older adults. Really nice summary. Among 18 to 49-year-olds, monthly rates of COVID-associated hospitalizations were 30 times higher in unvaccinated individuals and 3 times higher if you had just had your primary series or the monovalent booster. Graphics like this, where the interest is here at the end, where the bivalent booster is shown as the single dot, since they're kind of new, compared to getting the primary series compared with the green line, which is being unvaccinated. And there's a clear delineation that those who receive the bivalent booster are protected from hospitalization 16 times better than those who are unvaccinated and 3 times better than those with the updated booster. Death is important to reflect on, of course, and this is similar. You have an 18.6 times lower risk of dying from COVID-19 compared to unvaccinated if you elect the bivalent booster. What's the future for us? I don't know, but predictions are that COVID-19 will continue to circulate and evolve. Your alphabet soup is not going away. This virus wants to accommodate people and be better at least spreading, if not killing people. Yearly routine booster is likely to be important and will especially protect against severe disease. Combination vaccines are under works. So flu and COVID-19 are in an advanced stage. And just this morning, top line results were released from Moderna regarding RSV in a combination vaccine showing excellent protection. So maybe we have a trivalent mRNA vaccine every fall. I think it's time for us all to incorporate COVID-19 vaccination into routine well child and primary care appointments. When I round in the hospital, when I see my patients with mycobacterial disease, it has to be part of our conversation. So you've seen the summary slide before. I show it again now that you've seen some of the data underlying. COVID's not over. The mRNA vaccines are safe, effective, and helpful to mitigate morbidity and mortality. Omicron is clearly got tricks that are challenging us, but thankfully we have been able to respond with mRNA technology to have the bivalent Omicron booster, which is consistently in credibly done studies showing excellent prevention of hospitalization and death. And we all need to stay strong with regards to honing our messages to overcome vaccine hesitancy. So with that, I hope I'm within time, and I offer thanks again for what you're doing every single day and choosing to be part of this continuing discussion on how we're going to protect one another and ourselves and our communities against this next stage of the pandemic.
Thank you very much, Dr. Talbot. That was excellent. Laura, I think we have a few questions in the chat box, and we do have a few moments for questions. I will say before the end of the presentation, we've had a lot of questions. The slide deck as well as the recording will be available. I will send out that link to registrants once we have that posted, so stay tuned. You will be getting this information again.
Yeah, thank you so much, Dr. Talbot. We have a couple of questions. One from Casey is asking, should people who get the bivalent vaccine back when it first came out, so about 4 months ago, should they get another booster, especially if they're 65 and older?
Thanks. We're in that uncomfortable place of not having really any data regarding the decay rate of that protective antibody. There is no recommendation for a second bivalent. And as in the last slide, I think we're trying to move to annual and whatever needs tweaking to make that durable, I don't know. But right now, there's no such recommendation.
Another question. So will the bivalent become the primary series? It's becoming hard to get the monovalent for those who are finally willing to get the vaccine, and or those who maybe only received one dose of the monovalent.
A good question. I'm not privy to the cogitations of the ACIP or FDA, but indeed, it appears that the fact that the Omicron booster that's joined with ancestral strain is better than just giving an Omicron vaccine. So because I think it's stimulating the immune system with both the ancestor strain and the Omicron strain, there's overall a better and more robust immune process. But whether we go to that exclusively is in the hands of our federal and international partners.
Okay, great, thank you. And another one is sort of looking at staff. So suggestions on encouraging healthcare workers to get boosted when they say, you know, I'm already wearing a mask and don't need a booster again.
Well, you could make it mandatory, which is what we do at our institution. And we don't want to do that. We want to use shared decision-making routinely. We want people to be comfortable in decisions they're making around their own healthcare. And so, again, you're attending here now, I think will be helpful in that regard. And you can simply show some of the very recent MMWR data that if you've had the primary series but have not accessed the bivalent, we now have data to show that you're not going to do as well. Sure, you may be wearing a mask, but this has never been 100% effective, as we all know from what transpired pre-vaccine.
All right, great. Well, Mary Ellen, did you want to ask your question or should we wrap up?
Just a quick question, Dr. Talbot, and you had spoken a little bit about this, especially with vaccine hesitancy. what is your suggestion for folks who adamantly refuse the booster? And I'm thinking more of, patients that you may see on a regular basis in that particular moment in time. They are absolutely adamant. How long before you offer it again? And do you refer them to any type of information to help support sort of that conversation before you see them again? Because they were just trying to find different ways to keep the conversation going.
It's tough. And I know that you're taking this on in the longer term as well. But what I understand is that when people are at the extreme of the continuum, conversations are often only helpful to further entrench them in their resistance. So it can be counterproductive. So you need your spider senses out and try to determine, is this a person who has any sway toward access? If they're set against it, don't waste your time. That's one strategy. And maybe when they see COVID hit closer to home, maybe when there's enough data to show safety, how many more billions of people need to be vaccinated safely before they agree to that. But you see what I'm saying. I think it's the onus on you to check. I'll speak in first person. I need to check myself and make sure that I'm respectful and that I'm listening, and that my goal in that conversation is to understand where they're getting their misinformation, rather than my goal being, I'm going to try to persuade them into it. That it's a slight shift when you frame it as somebody who seems very resistant. I will still say it at the end of every one of my appointments. Do you think it might be time for your flu vaccine? Do you think it might be time for your COVID vaccine? No? Check. But I'm still keeping it on the radar in a respectful, open way.
Awesome. Well, I'd like to thank you, Dr. Talbot, for your time and giving us a great presentation for everyone that has joined the session today. Is much appreciated. I am hopefully sharing my screen.
We're seeing it again in
okay, I got the
draft mode, but
let's see if we can follow this. We can't. Oh, here we go. Okay. Okay, it's not as quick as my brain, I guess. Okay, so I just want to give a quick shout out for the last two sessions that we will be hosting on our Small Talk series. Next week we'll be talking about sort of continuing that conversation that we just spoke about with Dr. Talbot about motivational interviewing to support vaccine acceptance on January 25th, and then February 1st wrapping it up with immunization's role in chronic disease management. So we certainly thank everyone for participating today. I'll look for the link for the slide deck and recording soon. I will send it out to the registrants, and thank you for your efforts with vaccine uptake, and I hope everyone has a great day. Thank you again, Dr. Talbot.